Hello, my name is Paula Rowland, and I'm a scientist with the Wilson Center and at TIER. And it's my great pleasure to introduce a new series of talks that we are calling The Sciences of COVID-19, Connecting Education, Research, and Practice. These talks are hosted by TIER, and they're in the same spirit as TIER's Big Ideas lecture series. But in this context, we're focusing specifically on COVID-19 and recognizing that we need many sciences, both to understand COVID-19 as an illness, but also to understand and think through our response to COVID-19 as a pandemic. In that spirit, we're inviting speakers from within the UHN community with expertise in education, research, or practice to help us think through and understand some of the questions that are percolating right now in response to COVID-19, and also as we might start thinking about some of our recovery from this particular pandemic. So it's my great pleasure for our first talk to introduce our speaker, Dr. Daniel Buchman. Dr. Buchman is a bioethicist at UHN. He's a clinician investigator at the Krembil Research Institute. He's an assistant professor at Dalla Lana School of Public Health, and he's also a member of the Joint Center of Bioethics. Now, Dr. Buchman has a program of research that explores the ethical issues at the intersection between clinical practice and public health. And today his talk is going to be about sharing scarce resources during a pandemic. What's fair? Now, before I hand the screen over to Daniel, I want to just comment a little bit on our process. This part of the talk is pre-recorded. Dr. Buchman and I pre-recorded our conversation, primarily to avoid any technical glitches in terms of interruptions or playback. But in terms of the live series or the live stream that we're presenting on April 22nd, both Daniel and I will be listening during the live stream. And Dr. Buchman will be available as soon as the video is ended to engage with any questions that are being offered through Slido, either during the talk or after the talk. So please join me in welcoming Dr. Buchman to give his talk, and please stay tuned to engage with him directly as soon as that video is ended.
Thanks so much, Paula, for having me as part of this really exciting lecture series. I think it's really important to have these conversations and to raise these issues and to challenge these issues as well as part of a really rich public discussion. I also want to express my deepest and most sincere gratitude to all the healthcare professionals who are watching today, who are working and caring for patients, all the essential workers, from grocery store workers to people who are making online deliveries and are really supporting each and every one of us during this really challenging and uncertain time. And also to those who are caring for loved ones and who are right there and supporting people, because we're all in this together, and we can't do it without anyone. So thank you so much. So I think to situate our discussion today, I want to first ask or pose a couple questions. And we're talking today about sort of ethics in pandemics and how we should share absolutely scarce resources, really when there's not enough to go around. So how do we decide about that? And the question I want to pose is, what kind of society do we want? How are our decisions and the values that inform our decisions reflecting the kinds of society that we want to create for ourselves? Because in many ways, our decisions and the way we go about these decisions and implement these decisions, or if they're in frameworks or protocols, really reflect this idea of the kind of world that we want to live in. And to that point, an additional question I want to pose is, what kind of people do we wish to be? Now, this is a question that's often attributed and can go actually directly back to the ancient Greek philosopher Aristotle, who encouraged us to think about, well, when we're people who are faced with a really challenging ethical dilemma, it's not so much what should I do, but how can we act virtuously? How can we respond as people in the most virtuous sense that really reflects strong character traits in being the kind of people that we want to be and live in the kind of society that we want to be. So I'm going to put that out there as a way to frame or as a lens on our talk today, because I think these are really important ethics questions that we keep in the background. One fascinating thing about COVID-19, I mean, there's lots of fascinating things and tragic things, but it has really, in my opinion, and I think that of some others as well, has created a shared experience of vulnerability. Mm. And, of course, how this vulnerability manifests happens in many different ways, and the way it expresses itself really depends, I think, on our social location and where we're situated in society. But I think what the pandemic has also emphasized is how truly interdependent creatures we are, and how we really do rely on one another. And in that vein, I think one of the biggest challenges that I've seen over the last number of weeks is that, and something that can be particularly challenging, I think, for healthcare professionals, is that we end up shifting our gaze from the individual to the common good. Mm. And for healthcare professionals, we have our duties and obligations to our patients to promote their well-being, to respect them as persons, to not abandon them. But I think when we're making rationing decisions in the context of resource scarcity, we have to think of, well, what's the best for the common good? Now, this doesn't mean that we shouldn't think about this in non-pandemic scenarios as well. But I think this is, a lot of things like this are intensified or heightened in the context of a pandemic, and especially in the context of resource scarcity. And I think this can actually cause a lot of moral distress for many healthcare professionals, when their normal best practices may shift in the context of resource scarcity. And so when we're thinking about rationing scarce resources, particularly in the context of a pandemic, we think of different aspects of justice. So typically when we think about justice, we're thinking and distributing resources. This is called distributive justice. So a question you might ask is sort of, what's the fair distribution of material goods in society? So how should we, in a context of limited resource, when the demand for that resource exceeds the supply, distribute this finite good and material resource to individuals? But I think another aspect of justice also comes up in these discussions, and that's social justice. And social justice is concerned with access to social goods, whether it may be something like personal protective equipment, a ventilator, but also as we think about other social goods like rights or opportunities, education, knowledge, and of course, power. So as we are in this pandemic period and we're thinking about these really challenging decisions, I think that there's both two different kinds of justice frameworks that are at play that we need to consider. And again, as we're thinking about making these really, really tough decisions that nobody should ever have to make, but maybe or likely be in a position where they will have to make them, what this raises for us is, as I mentioned, our interdependence, but also that we as human beings have our shared interests, and these are our shared interests in safety, in our own survival, and our security, and that each of us are valued, and each human being is valued and has dignity and self-worth. And this, I think, this recognition of our interdependence, and that we do all, this is the common good, right? That we do have these shared interests, and so how do we realize that in these decisions? How do we try to honor these shared interests, and which I think is a very challenging thing to do when the demand for these scarce resources far exceeds the supply.
Thank you for that. And thank you also for bringing moral distress into the conversation, because I think that has also been part of our early conversations as we were thinking about this talk. And in particular, in relation to this topic, the idea of moral distress as people need to make decisions within the context of finite resources. So are there general principles that could help guide people as they start thinking through how to make some of these decisions that feel difficult and have been somewhat unthought of and unimagined before we had this large scale pandemic?
Absolutely, yeah. So I'll first say just a bit more about moral distress. So moral distress arises in situations where you feel that you know what the right thing to do is, but there's external constraints that are preventing you from doing the right thing.
Mm.
And I know that healthcare professionals on the units and in various institutions and long-term care facilities, in other other contexts throughout the province, the country, internationally, are feeling this really acutely right now, where we may not have, for instance, the available resources in order to treat our patients in the way that we know possible because of these external or what we think the right thing to do is because of these external constraints. And that can be very distressing, and it can lead not only to burnout, but also related things like compassion fatigue, because healthcare professionals want to do the best. And that's why people went into healthcare. I mean, I firmly believe that is because we want to do good, and we want to and do best by our patients. And this really can challenge us. So I think what's critical, and we can talk a bit more about this later, is another sort of corresponding principle around reciprocity. Mm. So knowing that healthcare professionals and other essential workers are faced with having to make decisions that they may not feel right now is the right decision because of whatever institutional constraints, that their institutions or their health systems, or even broader, are there to reciprocate, in the sense that saying, hey, we understand, we acknowledge that you are going through this right now, so we're going to provide the appropriate psychosocial supports and other benefits to people who are undertaking these additional risks or in these contexts, in order to support you in doing that. Because our health system depends on the ability of healthcare professionals to be at work and to do what they do best. And if people aren't coming to work, or they can't come to work, or they can't competently provide care, that's a huge public health problem. Mm-hmm. So to the second point about sort of what principles might guide us, and I want to first say that having a pre-pandemic plan in place before a pandemic plan happens can help alleviate, I think, a lot of moral distress, or just like in the moment decision making when professionals are not sure what the right thing to do is to have a plan in place. So some of this, in times of having this done in place in times of pre-pandemic phases, I think is also very, very critical. So there's been a lot of healthcare professionals and other scholars and ethicists who have devoted time to thinking about how should we make decisions in the context of resource scarcity. And I'll say that a lot of the scholarship on this has been done in context of let's say flu pandemics and others. But in healthcare, we're faced with resource scarcity a lot. And we do have to make decisions in context of resource scarcity when the demand exceeds the supply. So this isn't new to healthcare, but I think in the context of a pandemic, these issues are intensified. So what I have up here on the screen are what are called procedural values to guide ethical decision-making in a pandemic. And the ones I have in here are adapted from a framework by Daniels and Sabin called Accountability for Reasonableness, sometimes shortened to A4R, as well as a document called Stand on Guard for Thee, which was put out post-SARS from the University of Toronto Joint Center for Bioethics. And what these values are not, these are values that are guiding the decision-making process. So so I'll distinguish today between procedural aspects of decision-making, so the process of fair decision-making, how do we ensure the process is fair, as well as some values that decision makers can consider when implementing or making the decision. So these first ones are about what's a fair process for decision making. So these authors have talked about these different procedural values. And the first one is, is the process, is it reasonable? So the decisions that decision makers should go through are based on reasons. And typically what this refers to are, what's the best available scientific evidence, ethical principles, as well as values that stakeholders, so the people who are involved in making the decision, or actually the population or the group of people who will be most affected by the decision, can agree are relevant to meeting the various health needs in a pandemic. And so this can range from allocating a scarce resource like personal protective equipment to something like ventilators, which there's been a lot of discussion in the media lately. And the people who are making decisions should be made by experts, by people who are credible, as well as accountable. And I think, the question of expertise, comes up a lot in healthcare, and who has expertise. We know now online and social media, there's a lot of questions about who are experts in different domains, and I think that's worth unpacking a little bit. So what kinds of expertise are needed to make these decisions fair? And I'd be actually very curious to hear your thoughts on that as well. So that's what reasonable might be about. The second one is transparency. Is our process open and transparent? So the process in which decisions are made must be open to scrutiny by others. People must be able to access these decisions publicly. This is sometimes referred to as the publicity condition from Daniels and Sabin. And so decision makers should make this process transparent, right? We're not hiding anything. And I think that's what's really important and related to a value I'll get to later, is the value of trustworthiness. Are we demonstrating, and I say we as being decision makers or even institutions, are we demonstrating that we are trustworthy and that we are saying that we're going to do the things that we say we're going to do and not leave people worse off? So this trustworthiness and demonstrating trustworthiness is key for people who are affected by the decisions or other stakeholders to place trust wisely in the decision makers and in the decision-making process. The next value is the process inclusive? And so the value here about inclusivity. Are the decisions made explicitly with the people who are most affected in mind? Is there an inclusive process that works with affected communities or populations? Are they at the table? Who is at the table? Whose voices are represented? And not just voices are represented, but are they heard? And what weight do those voices have in the decision-making process? So I think it's critical that when rationing decisions, especially, are made in healthcare, that the group that is most affected are represented at the table, and that can be very ways in which these groups are engaged, are leading the conversation, are contributing to conversation. I think this is a question that comes up regardless of a pandemic scenario, but I think is again really important when we're thinking about rationing scarce resources. The next value is the process being responsive? Do we have do we have an opportunity to revisit and revise our decision-making process as new information emerges? In a context of a pandemic, and as I think as we've seen with COVID-19, things are changing all the time. This is a new and rapidly changing pandemic, and we're getting new information all the time, and decision makers are trying to make these decisions with the best available evidence possible. And I think what's also really important about the process is once we develop one, we say, okay, so let's implement it and try it out. But let's revisit, because things do change. Or you know what we decided upon it may look great on paper, but it may not actually work in practice. So there should be that opportunity to revisit, as well as have an opportunity to address disputes and appeals. So populations or individuals who are affected by the decisions should have an opportunity to appeal that decision. Now, I say this understanding that in the context of a pandemic, this may not always be possible, given the acuity of the decisions, given various time constraints, given pressures, given that we are in uncertain times. So in other areas of priority setting or resource allocation, I think there should be something built in, and if all possible, this should be built in. But I understand this may not necessarily be feasible. And the final procedural value to guide ethical decisions is accountability. Or are we being accountable here? So are the decision makers available to answer questions about their actions, omissions and commissions? And decision makers should be able to defend their actions or inactions. And these decisions should be grounded in ethical principles. Here's an example. There's a lot on this slide. There's a lot of values here. These are some what's sometimes called substantive values that can help decide ethical decision making in a pandemic. And this is by no means an exhaustive list. These are some common principles and values that scholars have put forward in consideration. But what I want to emphasize with some of this is that some of these values actually may be in tension with one another. So for instance, there might be a duty to care. So this is something that's enshrined in all healthcare professionals' codes of ethics. Duty to promote the well-being of their patients and not abandon their patients, with the idea of reciprocity. So I mentioned reciprocity earlier, and reciprocity is the idea that, we have, let's say, healthcare professionals putting themselves at an increased risk in caring for their patients and fulfilling their duties of care during a pandemic. And so institutions or health systems, whether it's, coordinated networks or provincial or federal, are they reciprocating appropriately, whether it's through compensation or, let's say, adequate PPE? So if there is inadequate PPE to care for a patient during COVID-19, should healthcare professionals still care for that patient? And that discussion has come up a lot. What are the limits of a duty to care? Is it an absolute duty, or are there some circumstances where people would agree that a healthcare professional should not care for their patient if there is inadequate personal protective equipment? So that's just an example of where some of these come into tension. I'm not going to go through each one of them, but just sort of to mention, I'll highlight a couple ones that often come up in rationing decisions in context of resource scarcity in a pandemic. So I think if you look at different rationing decisions, for instance, around, let's say, examples like around ventilators, most of them and a lot of the ethics advice actually will emphasize the utility value. And typically we can think of utility as maximizing benefit. So how can we maximize the greatest good for the greatest number of people? I mean, it's a very crude way of thinking about it, but it's one, how it's often framed. And this often translates in the context of rationing decisions. So how can we save the most lives or save the most life years? So this may translate in some contexts, in some decision-making frameworks to, not, who is the sickest that should receive this absolutely scarce resource, but who is likely to benefit the most. Now, what does benefit mean? Is this benefit clinically? I think sometimes either implicitly or explicitly, this may translate into quality of life criteria. Do people think that certain populations might have a greater quality of life post-intervention? And I think this is potentially, problematic and can create a lot of challenges. And I think we've heard loud and clear from disabled people that the idea of, benefiting the most might translate or might actually deprioritize some of these groups or disabled people from accessing a scarce ventilator. I think, or other scarce resources, right? You'll see in sort of any allocation criteria that human rights issues that shouldn't, these decisions shouldn't be people shouldn't be discriminated based on age, gender, sexual orientation, race, ethnicity, disability, and so forth. And I think that's critical and that's important that that's in there and that decision makers consider that. However, the concerns we've heard from disabled people in various communities is that, in fact, this utility criterion is what's called ableist and considers those who would sort of likely sort of benefit the most in terms of these life years. And I think that's something that decision makers need to take quite seriously. I think what also, implicit again within this criterion that's not perhaps often discussed enough, although scholars have raised the issue, is how do these allocation processes take into consider the social determinants of health? We have these very challenging decisions when patients are presenting, let's say, in the need of an absolutely scarce resource like a ventilator. And there's various criteria that decision makers have to follow and determine, for instance, who might, benefit the most. But does not take into consideration sort of the social conditions that contribute to poor health. And so a question from social justice, and I have social justice there on the screen, is, how should we take into consideration these structural drivers that contribute to worse health outcomes for certain populations? And are we unfairly disadvantaging certain disadvantaged groups within our policies and practices? So I think, this is, I do not envy decision makers who have to make these decisions. I do not envy the people who are working tirelessly to develop these protocols, because I really do believe they have the best intent and interest in people in mind, and wanting to make the best decision possible in a situation that's like absolutely impossible, I would say. But having said that, these are, I think, important pieces that do come up. Are we honoring sort of these principles here, and who's benefiting from our decision and who's left out? Talking about various populations who may not be able to access care. I mean, I think, again, back to some of the principles around equity and social justice. In our pandemic plans, and when I say whose, I mean like populations' interests are being prioritized, and whose aren't. Unfortunately, with any of these rationing decisions, and I think it pains every single person involved in the process, is that there just isn't enough to go around, and people, people would want to give adequate resources to everyone. I mean, I think even in non-pandemic times, we have this problem, which is made worse by the context of the pandemic. So it's, how are we, and I say we, again, being health systems, institutions, or decision makers, addressing the needs of those who are the most worse off? And how are we, in terms of principles of equity, how are we reintroducing services? How are we prioritizing services? How are we even addressing things in the preventative and sort of post-COVID stage in order to ensure that we're less likely to get into this situation in the first place, or at least minimize the harm or reduce the harm that may come from some of these decisions. So we have these values, the example list here of what can guide decision making. But I think in any priority setting process, these values are not necessarily, or the values that are identified in the process are not necessarily weighted equally. So this raises another, I think, important question for decision makers is, what values should be prioritized? And so are we going to prioritize medical utility, right? Are we going to prioritize issues around equity? Are we going to prioritize or be guided by or have a lens around something like solidarity, which I think is really a really important value in context of public health ethics. And so when we do, ideally in the pre-pandemic phase or even during the pandemic phase, when these decisions are being made, this is why I think it's critical to again emphasize that procedural value around inclusivity and having the different voices around the table, especially particularly of folks who are directly impacted by the decision. So we mentioned earlier about the idea around engagement. Whether engaging stakeholders, patients, diverse publics. I think this would be worthwhile to have a whole other tier rounds on that topic because it's so important. And I know there's some really great thinking happening at the Wilson Center and elsewhere from folks who are, including yourself, who are doing really amazing scholarship on this. And so, I would benefit immensely from learning from you and others who are working on this because this is such an important point. So, the question of what values should be prioritized, sure. But when we're making a decision and we're considering the distributive justice dimensions, we also need to consider, again, as I mentioned earlier, the social justice dimensions about the access to these resources. So one question that does come up a lot in the literature, it's not just what values should be prioritized, but who should be prioritized. And so when we're thinking about this in context of distributive justice, of distributing the fair distribution of goods across a population, but social justice, so who has access to this? So a debate that has come up in a lot of these pandemic ethics decision-making documents and in the literature is around the principle of instrumental value. And what this means is that some people suggest that certain groups of people in society who are critical to responding to a pandemic effort should be prioritized to access scarce resources. So sometimes people suggest that healthcare professionals actually should be prioritized for access to a scarce resource like a vaccine or a ventilator, because they have a specific skill set that's necessary in order to respond to the needs of the pandemic. And so we ought to prioritize them first. Others have said, well, hold on, healthcare professionals themselves, by and large, are a privileged group in society. They may be privileged socially and economically. They are more likely to be able to access these scarce resources anyway. So in prioritizing healthcare professionals or even other like paramedics or security workers or personnel or police officers or other folks like that does not necessarily ensure equity. If we're going to prioritize an already what's considered by many to be a privileged group in some respects. So these are important conversations that are being had. They are important conversations that will continue to be had, because this suggests, I think, that not just we have to weigh different values differently, but we have to really think, again, back to some of the procedural values I talked about earlier, about who who are these decisions intended to benefit and who will be left out? And can we defend our decisions to prioritize one group over another, not only just based on reasons and evidence and principles, but also sort of the ethical values? Can we point back to them? And are these values, have they been informed in a sort of inclusive way? Are they guided by the needs and interests of the affected communities?
That's a really salient example, and my goodness, what a difficult question that is to wrestle with.
Yeah.
Part of what I value in setting up this conversation between you and I, you had talked about your desire to have tough conversations during uncertain times. And thank you for being up to the challenge of that, because these are tough questions, and questions not only about what is the right thing to do, but really legitimate disagreements about what the right thing is and for who.
Yeah. Yeah, well, thank you so much for inviting me. And I agree. It's, these are like incredibly tough decisions, and in many cases, especially worst case scenarios, these are decisions that I wish nobody should ever have to make. But as we've seen in places like Italy and New York State, people do have to make them.
Mm-hmm.
So how can we make them in the fairest way?
I think that is a wonderful and important place to end and have some closure about acknowledging the hard work that's being done, the difficulty of the work that's being done, and paying attention to these notions of fairness and making use of the resources that we spent a long, long time developing, some of the resilience and the understanding and some of the ethical principles that we've already considered, and what else might we need to learn in the moment. So thank you very much. I'll look forward to continuing this conversation, but I will end this part of the recording now, knowing that we are actually live on Wednesday, April 22nd, and that we are both actually listening to this conversation again, and that you're going to be available to engage in conversation with people who are posting questions on Slido. But thank you for pre-recording this part.
Thank you. Thanks so much.
Thank you so much for taking the time to pre-record that conversation, Daniel. And now we're transitioning to the part of the presentation where we're live and we're interacting with the questions that we've received on Slido. Many of these questions came earlier in the week if you have appeared this morning. And what we're trying to do at this point is trying to recreate the dynamic and the intention of Grand Rounds type conversations and presentations. So we're trying to relate to the foundational science and core concepts. And we're using Slido as a way to try to use this technology to build in the interactivity and give the opportunity for questions. But we want Slido to support the intention of these kinds of rounds, which is connecting to the foundational science and connecting to the core concepts. So this isn't the spot where we're going to be answering specific policy questions or questions that are specific to particular organizations, but we'll try to bring the questions and reflect to your areas of expertise and how you might connect the questions to the talk that you just gave. So we're going to go through the Slido questions as they're appearing on the screen based on the number of upvotes, and we'll see how much time we have and whether we can address each of the questions. And we make sure before we end, we'll talk about what we'll do with the unanswered questions. Sure. So I think it makes sense for me to read them out to you, and then we'll just go through them and see how many we can get through.
Great.
So the first question that came up with 3 upvotes says, looks like it's written from a patient perspective. So it's understandable that people of all ages who live with chronic illness and or disability are concerned about their potential deprioritization for receiving life-saving resources and care. Can you comment on this and what patients might do?
So thank you very much for this really important question. I hear from colleagues and friends and members of communities of people who identify as living with a disability and disabled people that this is a major concern. I think on the one hand, this, as you said, understandable, is that people who live with disabilities have major concerns about this happening all the time, may have concerns around distrusting healthcare professionals or healthcare institutions. And this has come up a lot in recent discussions online and elsewhere about the potential of deprioritization. So, as I mentioned briefly in the talk, this has come up around the utility criterion, where maximizing benefit, or let's say medical benefit, or potential concerns or judgments around one's potential quality of life could have major implications for disabled people and other people who are living with chronic illness. So this is why I think it's important that within these frameworks, or particular allocation frameworks, that are looking at, absolutely, again, worst case scenarios of rationing absolutely scarce health resources, that considerations around equity are taken into account, as well as social justice, and ways of considering how to weigh different competing values such that people who are disabled are not unfairly, or at least even unintentionally, put at a disadvantage within these allocation frameworks. So I think this is a really important conversation to continue to have. And part of, again, the procedural values that I discussed earlier on in the talk around, how do we ensure the process for decision making are fair, is around that inclusivity value. So are people who are affected by these decisions, let's say disabled people in the case of this question, are they at the table? Are their interests and needs being heard, and is the process inclusive, and are they partnering with decision makers in deciding how these policies and procedures can be created? So again, thank you for your question, and this is an important one, I think, that we ought to continue to consider at present and in the days ahead.
The next question looks to have a very similar intent, and it's written from the other standpoint. So this looks like it's written from a staff perspective. We know that some people will have their treatment delayed or changed because we have less capacity to address their needs. How can we stop feeling like we aren't offering our patients our very best?
Thank you for that. This is tough, and I hear this from colleagues who are working on the units and in healthcare institutions, who desire to give our patients the very best all the time, and in a crisis context, in a pandemic context, in a context of uncertainty and absolute resource scarcity, I can appreciate how that this feeling, it can be very real and very true for many people. This is an unfortunate consequence of a pandemic situation, where people who have non-urgent care delayed, or appointments delayed, or things around screening or follow-up, and this can be unbelievably anxiety-provoking for patients and families, and I think, as this question is pointing to, for staff as well. How can we stop feeling like this? I think I would just acknowledge that it's normal to feel like this. I think I would not acknowledge that this is an unfortunate consequence of this. We wish that we didn't have to feel this way, and we wish the situation isn't what it was, but it is what it is. And I think there's many ways in which we can continue to offer our best, and many people are doing this each and every day, from being attentive to patients, from caring for patients, from being present with patients and families, and being that rock solid support that many of you are each and every day through this time of uncertainty. So I think when we think about what it means to offer our very best, we can think of it in multiple ways. One, in terms of the services that we provide, for sure, but it's also about the care we provide. And this is the low tech, the low tech care, the skills that many healthcare professionals have in addressing patients' concerns in sort of non-high tech intervention approach. But I can appreciate how this is incredibly difficult.
This next question that we have was put up on Slido before you actually gave your talk, and that question focuses around the idea of moral distress, which you did speak to. But I wonder if we could read this question, maybe there's something that you'd like to elaborate on. So it seems that pandemic responses are putting healthcare providers into situations that cause them moral distress. What is the impact of this distress?
Thank you again for a great question. So just to reiterate sort of what the definition of moral distress is it's a situation when you feel you know what the right thing to do is, but there are external constraints that are preventing you from doing the right thing. And this happens in non-pandemic scenarios, but I think it's also intensified in pandemic scenarios for sure. And I think this is a reality, but one that we can help mitigate in many ways. But the impact of this distress might be, and at least what we know from the literature, is the moral distress can lead to various forms of emotional harms, can lead to things like burnout, empathy fatigue. And this is a very, very real problem because not only may healthcare professionals be experiencing some of this emotional harm or even an exacerbation of mental health issues like anxiety or depression or trauma, but it may impact and very likely impact the healthcare professional's ability to care competently for their patients or care for the patients in the way that they feel they're best. And this is, thinking back to some of the questions that we've heard already, about offering our patients our best. I mean, these emotional impacts or negative consequences of moral distress we need to take seriously, and I think is actually a really important part of institutional and health system and provincial obligations around reciprocity. And so, because we are asking our healthcare professionals to put themselves at increased risk for taking on additional risks, because they are going and fulfilling their duties and obligations to their patients and families and increasing the risk of their experience of moral distress, which again, I'll just say that, the experience of moral distress and the consequences that are associated with it are not just borne by the individual. I mean, we're all, as interdependent, we have families and friends and ones where people we're connected and close to. And, our families and friends and loved ones, feel this as well. So part of, I think, that reciprocity principle is, are we making available the proper psychosocial and emotional supports to people so they can address those needs? Do people know where they can reach out to for help? How can we also, build capacity within the organization in the pre-pandemic phase and also during the pandemic phase for people to be able to sit with these really horrible feelings and feelings of moral distress and not let it lead to burnout. If we do let moral distress sort of reside within us and not sort of processed and addressed sort of sufficiently, it may lead actually to this concept that's discussed in the literature called moral residue. And that's when in some sort of future scenario, whether it's a day, a week, a month, a year, 10 years later, the distress that the person experienced, the moral distress that they experienced still lives with them and informs them, I guess, either for better or for worse, in how they might approach the care of their patients. So it's critical that we address this now, but also helping to build capacity within people to address it themselves in the days ahead.
Thank you. I think we probably have time for maybe one or two more questions, just to make sure that we close on time and give a process for follow-up. So I'm going to go to the next question, which looks like it is written from a patient perspective. Can you comment on why specific hospitals, and they gave the examples here of two different hospitals, in response to Toronto Star article, report that the policy is that COVID positive staff return to work if asymptomatic for 3 days without personal protective equipment? As a chemo patient, I'm a chemo patient to think that the only thing between the virus and me is the surgical mask is chilling, and then it has a statement unethical.
Thank you again um, for this comment. It's I can understand the distress and the anxiety that this person and others in very similar positions must be going through right now. So I'm not familiar with the Star article, but I can say that in general, this situation where various hospitals in the province, in the country, internationally, are developing policies around return to work, um, ideally would be informed by the best available science. And when I say best available science, we also know that in the context of a pandemic and a very rapidly changing pandemic, this the science is changing very rapidly as well. And so decision makers who are tasked with making very tough decisions around, for instance, staff return to work policies, are trying to keep up with the science and make the best informed decision that's possible that protects both patients and staff and anyone else who comes into contact with the hospital. And I can understand that this can be very challenging for people, and staff included, when the recommendations are changing by the day. And so, in context of uncertainty, we often will look for concreteness, for black and white answers, because that, I think, would help alleviate all of our anxieties. And unfortunately, we're in a situation that's not really conducive to that. So we have recommendations that might seem irrational, and I'm not saying that the policies that are raising this question are irrational or not. I'm just saying in general, when these are changing all the time, when there's concerns about personal protective equipment, when there's questions about does PPE really protect asymptomatic people or not? What's those trans? I mean, those are really important questions that I do look to my IPAC colleagues and to public health experts for advice on this, and trust that the recommendations that we're getting are with our best interests in mind. And to that point about trust, is it relates very much to concepts of uncertainty, because we require trust in context of uncertainty. To trust is to make ourselves vulnerable, and we want to place trust wisely in our institutions, in our provinces, in our health systems, in our national leaders, that they're going to act with our best interests in mind and not leave us worse off. But uncertainty really can really challenge that. So I appreciate the comment and the concerns that have been raised.
Thank you. So I think we just have a few minutes left to maybe see if we can just introduce one last question, but knowing that you probably won't have time to address it fully. And I'd actually like to skip ahead to the latest question that we received because it came following your presentation.
Okay.
So it just moved on me. Great presentation, thank you. So returning to the idea of expertise, how do we balance input from all stakeholders and not lose sight of the fact that some people draw their expertise from different sources? What do we do, for example, when lived experience suggests different action than science?
Wow.
2 minutes.
2 minutes. That is a wonderful question that I cannot address in 2 minutes, or I think it'd be a wonderful concept for rounds as well. And I actually don't even think the question can be addressed in the context of one rounds as well. I'll just say that expertise is a concept that many people have been looking at very seriously. And I think some perspectives are changing on the idea of who or what counts as an expert. I think in the context of the pandemic, we've seen the importance of having credible informants around things like such as science. And I do believe that people who have lived or living experience of a health condition or certain types of experience is an important is an important source of expertise, and this is something that ought to be amplified. And I'm not just talking about in pandemic contexts, but this, I think there's a constant process of negotiation, of balancing different perspectives that come to the table. I think, when we think about expertise, we need to take very seriously the needs and interests of people who are living with those experiences, and make sure that they're amplified and um, are co-created as part of the pandemic planning responses. And again, not specific to pandemics, but to other responses as well. Um, I think it's an important question and something that we should continue to address. Again, ethically speaking, I think it's important to find some ways for healthcare professionals to have some, and I'll use a very jargony term here, called epistemic humility. And that's realizing the scope and limits of one's knowledge and experience and sort of imagination about what it's like to be someone else, or live like someone else, or living with something or something else. So I think finding a way to balance those lived experiences and expertise as a way of knowing, sort of alongside with sort of perhaps the scientific or epidemiological or public health expertise of others as part of the conversation, is this constant active negotiation.
Yeah, thank you. I agree. That could be an entire round and a conversation on its own. So thank you for engaging with each of these questions so thoughtfully. Now, you're unique as a speaker because not only do you have a program of research that's relevant here in terms of informing how we understand COVID-19 and a response, but you, in your role as a UHN bioethicist, you answer questions for staff in particular kinds of ways. So you had suggested that you could do something with some of the unanswered questions from today.
Yeah, so thanks, Paula. So I'm part of the UHN bioethics team, and there's a group of 7 of us across all of UHN. And as many of you on the line know, we respond to clinical, organizational, and research ethics issues. So from the bedside to boardroom, and the bench as well. And so we're available for individual consultation, but also at the end of this talk, in terms of the questions that weren't able to be addressed, we can send them. What we'll do is we'll collate them and then send them back to the UHN bioethics team, and you'll have the benefit of hearing from multiple voices, sort of together in consensus around answers to particular questions, and we'll have that available to post on, I guess, the TIER website, and we can also link it to the UHN bioethics website as well.
Well, thank you very much for being able to do that follow-up work. And thank you in particular for the amount of time, effort, and attention you put towards this talk and to engaging with the questions. We certainly would like to host more talks like this. So we're open to your feedback from anybody in the audience listening today about the structure, the content, and suggestions for future topic areas to help us think through some of the sciences that inform our understanding and our response. Thank you to TIER for the support, to Patty Leek for all the technological support in the background, to Michael Johnson from UHN Digital for helping today happen as smoothly as it has. And I think we will close there on time. And thank you everyone for your participation.
Thank you, Paula. And thank you everyone online and for your questions.